TX has a unique audio structure, combining a real-time magnetic driver with a dynamic.
Good evening, sir. Are you able to hear?
Good evening. Yes.
Good evening, sir. Good evening, sir. Welcome, sir.
Good evening, Sivan.
Sir. Good evening, sir.
Good evening, sir. Ma'am, good evening, ma'am.
Hi.
Rachna, ma'am. Good evening, ma'am.
Hi.
Your audio is clear, ma'am. Yeah.
It's clear.
Yes,
Can I check few slides?
Yes, ma'am. Please do it, ma'am. I'll stop share. You can share it.
Yeah, 1 second.
Yes. Ma'am, there's some bright light on your right, I guess.
Yeah, I'm just stopping because I use this as a, Yeah, is it okay?
Right, ma'am.
No.
It's
yeah. Or I can stop.
Yeah, it's good now. It's good now. Yeah.
Is it fine?
Yes, ma'am. It's fine, ma'am.
Give me a minute.
Yes, ma'am. Dr. Thangavelu sir welcomes you, ma'am. He is the director of pediatrics of Mehta's.
Good evening, Dr. Shadubey. Welcome to the webinar.
Good evening, sir.
Welcome to the webinar.
Good evening.
Good evening. Good evening.
I sent the mail, sir. Should I send you the WhatsApp too, sir?
I'm not able to share my screen.
No, share screen. There is an upward arrow. I think you are familiar. No, green one, share screen, upward arrow. Click that.
Yeah, I know, sir. But it's saying host disabled, participant sharing, screen sharing. So
yeah,
so
he
you'll
has
have
not
to
made you as a co-host. Okay, I'll ask him to. Shivan.
Right.
Yeah. Shivan.
Sir?
You have not made her host, co-host. You make it co-host.
Sir, it's actually not necessary. She can share screen.
No. It is, she gets an intimation like that you are not permitted. No, usually it comes in the panelist list.
Ma'am, please try sharing screen now.
Yeah, it's saying host disabled, participant screen sharing.
You can.
I'll do that, ma'am. I'll do that.
You can 3 dots. You can make her co-host so that you also will retain that.
Sir, there is no co-host. There is only one host, so I can make ma'am the host now.
It looks like Zoom has got different dishes. I think. Some you will have the 3 dots. You can make someone co-host, and still you retain your power.
Okay.
Ma'am, you will have to share your screen now, just to.
Okay, I'm just doing it. Yeah. Desktop 1, PowerPoint share. Are you able to see it?
Yes, able to hear, able to see the slide.
Great. I just want to move to one slide so that I can check whether the videos are playing. Just only few have videos actually, but still I want to check once.
Ma'am, there is a little bit of lag in the voice and the video. I think internet is a bit slow or something. Is it so, ma'am?
But it will be there, Sivan, 5 to
we'll
10
check
seconds
that,
lag
and
usually
otherwise,
happens.
All right. If you want to share to some other source, you can do it.
otherwise yeah, and also what I'll do, I will stop my video so that like the
Yes, ma'am,
presentation becomes more smoother. I
Yes,
mean, if
you can do that. You can do
yeah,
that.
yeah.
During the Q&A session, we'll change it.
That always works best.
Yes, ma'am. Yes.
Are you able to see this video? The cursor is running fine.
Yes, ma'am. The video is running, but there is some lag in. But that happens, ma'am.
Okay.
Yeah.
Let me do one thing. Let me stop the video and check it. Okay. So I'm stopping my video and now see the quality. Does it improve?
Better, I think, because all of us can stop our video except during talking. That will make the better.
Yeah. Is it okay?
It
Yes,
looks better than
perfect.
earlier.
No, it's
No, it
perfect,
is
yeah.
interrupted earlier.
It is a little better, but still there is some interruption.
Okay. So let me see if there is, I can switch to another internet source, right?
Yes,
So,
ma'am. We have time, ma'am. We have more than 5 minutes.
okay. Let me check.
You can have your phone also with hotspot. That also will support.
Yeah, actually I have three things, but at times with the videos, this is the issue. Let me just see it where it is right now. Okay. So what I'm doing, let me go to my Wi-Fi and then just try it if it is working well. Because you close all the doors, so the Wi-Fi source becomes like,
Ma'am, if any other device is connected to the Wi-Fi, you can disconnect that.
no, there is no other device really. Wait a minute. Let me. Yeah, this was the one which we were checking. Can you see the screen?
Ma'am, you haven't shared it yet.
Oh, 1 second. So let me share screen and not able to see it. Can you see it? No.
No, ma'am, you haven't shared it yet.
Yeah. Yes, now I can.
Yes, ma'am.
So just see if this internet is better or it's the same. See, let me tell you, the video has very subtle things as far as clinical events are concerned, right?
Okay.
So let me go to the previous slide. Maybe
The slides are moving fine and your audio is perfect. But the
Right.
video was a little bit, but that happens, ma'am, even with the best internet. So that's not an issue.
Just check this.
Yes, ma'am, this is superb.
So, that is an EEG video
That is
actually.
a video EEG. So that's the inherent problem in that. I get it, ma'am.
It's related to video EEG. So the just see these. If I run.
These are all perfect, ma'am. This internet is much better, I guess.
Okay.
Perfect.
Fine, right? And there's no sound on it to you, right? There is no sound for the videos because I don't want that. These are the only videos I have.
All right, ma'am. They're perfect.
Yeah. Okay.
You can narrate that whatever you want to convey in the video EEG thing. You can just tell it verbally so that we understand.
Yeah, actually, video EEG is again very few subtle moments, subtle jerks. It doesn't have anything which is very obvious. Actually, which is why it is meant like that. So those obviously you will see two jerks. One which you saw just now.
Okay.
And one is later when she's clearing her glass. Yeah, you saw that? Did you see
Much
that?
better. I think it was a problem of the internet that time. This internet is much faster.
Okay, great. So these are the ways, subtle things I just want to show here. That's it.
All right.
Okay.
All
So I'm just stopping my screen share.
Yes,
Okay.
ma'am. I'll share. I'll be the host for a while until we finish with the introductions, and then I'll make you the host.
Sure, sure.
Hello. நீங்க ரெஜிஸ்டர் பண்ணீங்கன்னா ஆட்டோமேட்டிக்கா வந்துரும்.
Ma'am, have you?
இல்ல அதுல கிளிக் பண்ணீங்கன்னா இல்ல நான் பண்ணேன் கிளிக் பண்ணா ரெஜிஸ்ட்ரேஷன் வரும். ரெஜிஸ்ட்ரேஷன் பண்ணுங்க பண்ணா ஆட்டோமேட்டிக்கா வந்துரும். அப்படி இல்லைன்னா இதுல யூடியூப்ல வரும்.
Yeah, you were saying something?
Ma'am, nothing, ma'am. I was just checking this. I had to reclaim host in order to screen share.
Acha.
Okay. This is a webinar add-on in Zoom, so this is a bit new. It's different from the routine Zoom.
Okay.
The routine Zoom is a Zoom meeting. The Zoom webinar is an add-on. So
Right.
there are some new things which I think I've nearly figured everything out, but there are still certain things.
Even I think you will be a tough examiner in the future, I think. Very difficult to pass with you. Expectations are high.
No, sir. One second, sir. I think Dr. Udani sir just texted me. He's joining in a few minutes.
Sure.
He texted me like 5 minutes back that he's joining in 5 minutes, so he must be here anytime now. So it's the broadband Wi-Fi, is it, ma'am? This one?
Yeah, this one is the broadband, but I have a study area which is kind of, little disconnected from the main zone. That's the reason. Otherwise, internet in the main is not an issue, though there is a Wi-Fi extender, but still I will keep my video off so that the presentation is okay, especially during the videos, right?
Yes.
The slide shouldn't be an issue. And the audio is okay?
Yes, ma'am, the audio is fine.
Right.
Good evening.
Dr. Udani sir is here. Good evening, sir. Welcome, sir.
Good evening, sir.
Good evening, Mahesh. Good evening, Mahesh, sir.
Good evening.
Hi, how are you?
Good evening, sir.
Good evening.
Good evening, sir. Welcome to the webinar, sir.
Thank you. Rachna, if you're going to show videos, then maybe you should optimize your Zoom before you share your screen.
Sir, I don't have too many videos. I have optimized it. I have just kept 2 slides which have videos. And what I can do is I can stop my video while I'm doing that video. And I just checked it with Shivan. And
Yes, sir, we just checked it and it's working fine, sir.
No, what I meant is that Zoom itself has at the screen it says optimized video to Zoom.
Oh,
Prevent jerking. Otherwise, the thing comes, it sort of jerks.
okay.
So when you share the screen, on the bottom part of the screen, there'll be a tick mark for optimized video for Zoom.
Okay. So do I check that right now?
I'll do it.
Is this yours? You can check it now if you want, but it'll be only when you share your screen.
Yeah. So we are about to start. So I guess it's okay. I can check it that time and maybe
Yeah.
it can be suggested if it's not doing well.
Sure. How will this work? How is this actually going to work?
Sir, you're talking about the webinar, sir?
Yeah.
Sir, actually, we'll have ma'am as a speaker, sir.
I know that. I'm saying after that, what?
So the lecture will last around 30 minutes, sir.
Okay.
So I can just tell you what it is. So I haven't really, since keeping in mind not crossing more than 30-40 minutes looking at the attention, I have not added the vast thing, just tried to keep it more into unprovoked and how to handle it.
Sure, sure. Fine, fine.
Not gone into the treatment and detailing it.
And then there'll be just question answers, correct?
Yes, sir.
Which you want me to manage or you're going to be managing or something?
Sir, I thought that me and Dr. Thangavelu sir would.
Good idea. Good idea.
So,
Collect, no, sir, complete it. He has mistaken it. We'll collect the questions and post it to you.
yes, sir.
To the
you
chat,
can-
to the
you can-
chairpersons as well as for the speaker, sir. Then you will have to answer. We will collect and post the questions to you just to help you out.
The moderating job will be done by 3 of us, sir.
Okay,
And,
great. Okay.
Ma'am,
I just wanted to find out.
Can give your comments, sir.
Shivan, Dr. Pandian has come, I think. Sir, welcome, Dr. Pandian.
So welcome, sir.
Dr. Pandian, but I have not seen your screen, sir.
So he has not
Dr.
done.
Pandian is in the chat box. I could see
Yes, sir, he's joining.
joining.
Good evening, Udani sir. Good evening. How are
Good
you,
evening. Good evening. How are you? Everything good?
Very fine, very fine. Thangavelu.
Yes, sir. Welcome, sir. Good evening,
Yes,
sir.
Good evening, sir. Welcome, sir.
Good evening, sir. Welcome.
Yes, sir.
Good
Good evening,
evening.
sir.
Good evening to all of you, Dr. Mahesh,
Yes.
Dr.
Good evening, sir.
Rachna, Dr. Udani. Good evening.
Good evening.
Sir, I think it's 7 now. If it's
Can
fine,
start.
we can start now, sir.
154 participants. I think maybe even more.
I think they'll join with time, sir. I think we can start with the introductions now. So, can I start, sir?
Yes, please. You can
Please.
start.
Just a second. I'll finish the unmuting work. So I'm unmuting, sorry, I'm muting everyone, sir. If you want to speak, you can unmute and speak, sir. So if you're able to hear me, sir, please give a thumbs up so that I can start.
Yes.
All right, sir. Good evening, professors, teachers, colleagues, students, and friends. On behalf of the Department of Pediatrics and Pediatric Neurology at Mehta Multispecialty Hospitals, I welcome you all to the second session of the Practical Pediatric Neurology webinar series. I am Dr. Shivan and I am joined by Dr. Thangavelu sir, the Director of Pediatrics of Mehta Children's Hospital, and Dr. Mahesh sir, who is the head of the Pediatric Neurology Services. And we will be moderating today's session. Today's talk is on the approach to the first unprovoked seizure, what to do next. To deliver this talk, we have Dr. Rachna Dubey ma'am, a passionate teacher and an astute clinician. I'll be introducing her formally later. We also have three eminent clinicians to chair this session, Dr. Rajesh Udani sir, Dr. K. Pandian sir, and Professor Annamalai Vijayaraghavan sir. It is my proud privilege to introduce Dr. Rajesh Udani sir. His name is a well-known one to most of you. He's an exemplary clinician and a senior pediatric neurologist in the country. He did his MD Pediatrics in 1981 from Mumbai. He received the prestigious Diplomate of the American Board in Child Neurology and Child Neurophysiology. He's presently working as a senior consultant in child neurology and epilepsy at Hinduja Hospital and the BJ Wadia Hospital for Children. He has received multiple awards and delivered many orations, including the late Dr. D.G. Gunn Oration 2012 for eminent pediatric neurologists in Mumbai, the late Dr. Shantinal C. Sheth Oration at Pedicon 2014. He was conferred the Dr. G.V. Koppikar Oration at Nashik in 2017. He was felicitated by the Indian Society for Pediatric Neurosurgery and the Asian Australasian Society for Pediatric Neurosurgery at the 28th conference of the INDSPN and the second annual conference of the AASPN in March, between March 24th and 26th, 2017 in Mumbai. He has 52 publications in various journals and 18 chapters in textbooks. Apart from that, he is a member of many prestigious associations, including the International Child Neurology Association and the International League Against Epilepsy, which is a prestigious body in charge of epilepsy all over the world. He is also a member of the Asian AOCM and also the Child Neurology chapter of the Indian Academy of Pediatrics. On behalf of our hospital and IAP Tamil Nadu State Chapter and IAP Chennai City Branch, I welcome you, sir. During this pandemic, we had the opportunity to listen to many of his talks, which were primarily focused on improving the clinical acumen in pediatric neurology, and we have vastly benefited from that. So, I welcome you, sir. I now request Dr. Mahesh, sir, to introduce Dr. K. Pandian, sir, and Dr. Thangavelu, sir, to introduce Professor A.V., sir. Please unmute yourself to speak, sir.
Good evening, all. On behalf of Dr. Mehta's Hospital, we welcome Dr. K. Pandian, sir, who is a senior consultant pediatric neurologist at Chennai. Dr. Pandian, sir, has completed his MBBS from Stanley Medical College in 1970. He was the best medical student of Madras University. And he completed his DCH and MD Pediatrics at the Institute of Child at Madras Medical College in 1980 and completed DM Neurology at Institute of Neurology at Madras Medical College in 1986. He was a former assistant professor of pediatrics and assistant professor of pediatric neurology at ICH, and he is a founder member of pediatric neurology and IAP subspecialty chapter. He has contributed to neurology chapters of IAP and textbook for undergraduates. And his areas of interest include epilepsy and behavioral disorders. He is an astute clinician. We welcome you, sir, for this webinar.
Good evening, all the friends. I'm happy to introduce Professor Annamala Vijayaraghavan, who is a senior consultant pediatrician, academic coordinator of Mehta Multispecialty Hospital. He's an associate editor of Indian Journal of Practical Pediatrics, past president of Indian Academy of Pediatrics, Chennai City Branch. He got a lot of prestigious awards during his tenure as a president, and he's going to receive many awards from the president IAP. He also retired as a deputy superintendent of Institute of Child Health and Hospital for Children, affiliated to Madras Medical College. He's contributed articles in national journals, certificate of merit at KMC Chennai. He's a PALS and BLS instructor. His field of interest are general pediatrics and critical care. We are happy to invite you as one of the chairpersons for this session of webinar today, Dr. Vijayaraghavan.
Thank you, sir.
Over to Shivan.
I am happy to welcome and introduce the speaker for tonight, Dr. Rachna Dubey. Dr. Rachna ma'am did her MD in pediatrics from Seth GS Medical College in KEM Hospital, Mumbai. She did her DM in pediatric neurology from the prestigious All India Institute of Medical Sciences, New Delhi. She is currently working as a consultant in pediatric neurology in Medanta Hospital, Indore, Madhya Pradesh. She has received the following prestigious fellowships. She did a fellowship in epilepsy and electrophysiology from the Cleveland Clinic, USA. She also trained at the Institute of Myology in Paris, France, in neuromuscular disorders. She also received the neonatal EEG ILA fellowship from Cambridge, UK. She also was a recipient of the ILA fellowship in pediatric epilepsy in San Servolo, Italy. She is a faculty in National Pediatric Neurology and Epilepsy conferences. She has been a faculty in these conferences and workshops, and she has 10 book chapters and more than 20 publications to her credit. She is a very passionate teacher, and we have been students in proxy of Dr. Rachna ma'am. So we are very proud and happy to welcome her and introduce her to the audience of Tamil Nadu and the rest of the country. So I welcome you, ma'am, to deliver the lecture on the approach to the first unprovoked seizure.
Thanks a lot, Shivan, for that kind introduction. And also, I have respected chairpersons, Dr. Udani, Dr. Pandian, and Dr. Vijayaraghavan. And it's an honor to be in front of all of you and astute clinicians and also the students. And hopefully, I should be able to do the justice to the critical clinical topic. I mean, there cannot be a more burning issue than this when it comes to pediatric neurology. So I should start sharing my screen. Just let me know whether it's working fine. Are you able to see it?
Yes, ma'am, we're able to see it. I request the participants and attendees to drop in your questions in the Q&A session, please. Thank you.
As today's topic is first unprovoked seizure and what next, and we can imagine the magnitude of this issue whenever we are sitting even in general pediatric OPD or emergency room, or we are a pediatric neurologist or epileptologist. So let me start by sharing something like, which is more concrete and where we, base our knowledge upon. So let's see, yeah. There are a few definitions which we'll be sticking to throughout the presentation. So I just want to kind of refresh them. And I'm sure that whenever pediatric epilepsy or seizures are discussed, we could be hearing them again and again. Just 1 second, hide the self-view.
You can press the icon in the left bottom corner.
Yeah, I'm sorry, 1 second.
The forward arrow in the left bottom.
Yeah. No, I'm doing that only. Can I just want to stop the camera so that the video is not an issue? That's the only thing.
Okay.
Yeah. Whenever we say that are we dealing with a seizure, then obviously this is an ILAE 2014 definition, which has been followed, and transient occurrence of signs and or symptoms due to abnormal, excessive or synchronous neuronal activity in the brain. So this is, we can see that this is very, very non-pragmatic or non-practical kind of definition, but yes, it tells us what to look for. They can be signs alone, they can be symptoms alone, or they can be mixed of it, and what could be the underlying pathophysiology when we are looking at a patient with seizure. And convulsion, of course, could be a part of seizure. Not all seizures can be convulsive. So motor manifestation of a seizure is termed as convulsion. So they cannot be used interchangeably, especially when we are looking at more of medical vocabulary, or when we are using it in terms of epilepsy and classification. Coming to why we need to really have a seizure phenotype or a seizure type. We all know as we go further that seizure is truly a substrate for epilepsy. So everything begins with seizure, and we can say it's almost a level 1 when it comes to a diagnosis of epilepsy or epilepsy syndrome. So obviously we need to understand everything about seizure, because everything begins here. Coming to this again, 2017, 2 documents which have come up, which are related to seizure classification, and epilepsy classification. This is something which is more of a concise pattern which has been given to us, where we can say seizure can be either focal or generalized. They can be unknown or unclassified. And again, when we come back to focal, they can be aware or impaired awareness, which can happen over a period of time or in the beginning or at the onset itself. And they can have motor or non-motor onset. Something which has been given as a freedom in the last, what we can see, is focal going into bilateral tonic-clonic. So which is earlier was called as secondary generalization. And again, focal, which could be earlier was called as partial. So these are certain terminology changes, which obviously we are getting used to, and it is getting more and more established. Generalized onset, motor or non-motor. Non-motor are predominantly absence. Unknown onset gives us a freedom to write down whether unknown onset is a motor or a non-motor seizure. And obviously the unclassified ones, where we are not able to classify them exactly, that are we able to make out the onset, are we able to make out the semiology. Something which I would like to emphasize here, that for neonates, there is a different seizure classification, which we'll be seeing more in a concrete manner in time to come. So which will be exclusively for the neonatal seizures. This is a cartoon which we often keep looking at ourselves. And something which we really ponder, that whenever we say generalized, it is something which is truly generalized, or it is perceived more as generalized. But yes, we can always say that whenever we are saying it is generalized, that means we are almost certain that it is bilateral, bihemispheric, something which has suddenly spread, and it is being perceived as generalized whenever we are looking at patient in terms of clinical manner. And it includes cortical, subcortical structures in varying proportion and fashion, and may not be necessarily entire cortex. So though we are using generalized, but it has its own caveats. But right now, obviously, we have been using the term as generalized itself. Next, going to the focal seizure. And we all understand that when we say focal, we mean they are originating within a limited network, which is onto one hemisphere or one region. And it is more discretely localized, and it may remain localized or can have a connectivity or a circuitry, and which can go into another hemisphere itself or also, and we call it secondary generalization, or more so bilateral tonic-clonic fashion. So this is the basic when we say focal onset or a generalized onset for a seizure. And again, to remind ourselves that whenever we are saying focal or generalized, it is more so related to the onset, as even a focal onset later, when we see it later, may look bilateral or may look generalized. This is an expanded version. And as we can see that the motor, non-motor onset are being further classified. And we have a lot of terms which we were always using something or the other for have become, more specific, like epileptic spasms, hyperkinetic, behavioral arrest. So all these terms are finding a place, which gives us more freedom to be concrete on a seizure whenever we are classifying it. Again, coming back to unknown onset and unclassified, and where again we can mention those cases where we are not able to put them into a focal or a generalized box at that point of time. Eyelid myoclonia, myoclonic seizures, atonic, myoclonic atonic. Again, these have become more established terminologies now other than myoclonic astatic, etc. So these are three documents which I guess everyone who's handling seizures or epilepsy should go through. 2014 seizure definition, 2017 two papers which are published on epilepsy and epilepsy syndrome and seizure classification, because the glossary is very handy and can be handled whenever we are seeing patients of seizures and epilepsy. And slowly it gets established how to go to the next level, and how to identify seizure types, and how to at least try to reach next levels of classification, diagnosis, and definitions. Coming to the epilepsy definition, as I was saying, that seizure is a substrate, and ultimately we want to reach the diagnosis of epilepsy versus no epilepsy. So after the seizure, we come to the next level of epilepsy, and 2014 definition, the first one, we have been knowing this for quite some time, which is at least 2 unprovoked or reflex seizures occurring more than 24 hours apart. So reflex seizure finds a place here, which we know that is provoked, but still is an epilepsy. So first is very clear cut, and something which we know that if there are multiple seizures within that 24 hours is still counted as one. So those are some practical points which we have to remember whenever we see such cases. Number 2, I have purposely left gray, because that is the gray zone which many of us face, and those are the things which we'll be discussing further. That means if we have only one unprovoked or reflex seizure, single, and there is a probability of a further seizure similar to the general recurrence risk after 2 provoked seizures. That means we are seeing that patient as a first seizure case, but still to our knowledge and whatever the patient has in terms of clinical or investigation capacity, we are able to predict that this patient will behave in future like 2 unprovoked seizure, and at least will have a general recurrence risk of 60% in next 10 years. So this is something which is still left to the person who's assessing the patient and also the clinical details. And third, again, becomes very, very clear cut, where if we have a diagnosis of an epilepsy syndrome, it falls obviously in the domain of epilepsy itself. So this is a framework which we often look at very, very carefully, and it is explaining the levels very well. That means if we have seizures, then are we able to tell that are they focal, generalized, or unknown onset? And if we have clear-cut seizure types, is it fitting into the definition of epilepsy? That means either the number 1 or the number 2 category, if they are multiple or they are single. And if yes, then what is the epilepsy type? Is it focal, generalized, combined, or unknown? So that's the level 2. And coming to level 3, which will be epilepsy syndrome, are we able to say electroclinical syndrome, which this patient could be having? Because obviously it will have treatment and prognostic implications. And as we can see on the right side, at each step, that means at seizure level, epilepsy level, or epilepsy syndrome level, we have freedom to select the etiology. Like the patient, whichever we are evaluating, whatever is the cause of seizure, epilepsy, or syndrome, are we able to say it could be structural, genetic, infectious, metabolic, immune, or unknown? Or can we pick multiple out of these? As we know that tuberous sclerosis will have structural as well as genetic. Biotinidase will have metabolic as well as genetic. And neurocysticercosis, gliosis will have infectious as well as structural. So obviously we have freedom to select multiple. Of course, one remains the primary. So 3 levels of epilepsy diagnosis, selecting the etiology category. And on our left, there is a big blob of comorbidities. That means someone who's having learning, cognitive, behavior issues, sleep disorder, obesity, endocrine problem, because all these comorbidities will ultimately add up to the overall prognosis and also the treatment decision and also the additional help with the patient will need. So when we look at this framework, this is very, very complete, and in fact tells us, like, whenever we come across any seizure, what is the way forward and how do we reach further in terms of patient management. Now coming back to the first slide, which is like, first unprovoked seizure. So whenever we see first unprovoked seizure, I feel like, we can have many questions, like, to sort out the moment we see the patient. But yes, first unprovoked seizure. So these three themselves have to be defined much, much more closely and much, much more elaborately. So when we say first, we need to be really certain, and it's not uncommon that when we probe further, 7 to 10% patients may have had seizures in the past, which they were not able to recall. Number one, they were thinking they were just some kind of phenomena which they need not bother about. So 10% is a big number. In fact, it can go up to 10 to 20% also. This was one of the studies which they said 7 to 10%. Nocturnal seizures could often be missed, and it can happen to benign or self-limiting focal epilepsies in childhood, where the seizures are often nocturnal. And it may happen that minor events where parents have observed children in postictal state or only with vomiting or only with autonomic phenomena, and those could have been the first seizures rather than the one which they presented with. At times, they can be unsupervised. And as I said, autonomic phenomena can often become unrecognized as seizure. And something which we always have to note that are there any febrile or any provoked seizures as well in these patients? And also knowing the natural history of epilepsy is very, very important. Somebody coming to us with absence or myoclonic seizure and telling us that these are the first event, we will be able to tell ourselves that we need to probe further, because it's unlikely that they can be single seizures with someone having this kind of epilepsy or epilepsy syndromes. So first, yes, we have to define it in a given case with a good and detailed history. This is something which I have just tried to explain it to you, what I was saying just now. So 14-year-old girl, she presents to ER in a postictal state. There is history of an early morning convulsive seizure after getting up from sleep, and she was found frothing, unresponsive in her room, and she had jerking of limbs both sides lasting 3 to 4 minutes. So yes, this is first event, and there is no obvious history of similar event in the past. Now, since we can see that this patient had a clear-cut seizure and she was well received, and there was nothing which was provoking at that point of time in terms of routine labs and blood pressures, oxygenation, etc., etc. So the first thing which was offered to her was an EEG, and we can see here, I hope that what I want to show here is visible. So something which just happened was a minor jerk. It will happen again. So we saw this jerk. So in this brief video itself, we can see that she has jerked twice, and which was never reported by the patient. So these were the events which were minor events and minor seizures, which this patient was getting regularly. But she presented only when she had tonic-clonic, more evident and more apparent event. So often the first may not be the first. And as you can see, the EEG running in the background is showing us that she has classical generalized epilepsy characteristics of 4 to 4.5 hertz spike wave discharges. And she is a patient of idiopathic generalized epilepsy. So the moment we see this, we know what we are dealing with. We know she has early morning seizures, she has myoclonic and tonic-clonic seizures. We know her age group, and electroclinical syndrome of juvenile myoclonic epilepsy, and the treatment plan and prognosis will be clear-cut. If we would have missed this possibly, then this would be taken as first unprovoked seizure. We tell them that we wait for the second one, and then we investigate further. So it's very important that we go into the details, and also knowing the semiology, knowing that this age children can have juvenile myoclonic epilepsy and it presents with early morning seizures, then probing further can always give us more answers. Coming to the next point, which is unprovoked. So reflex seizures are obviously provoked, but as we know that now they are very well included in epilepsy. So writing, eating, arithmetic, hot water, everything they are counted into reflex seizures and provoked. There is one thing which I guess, as we deal with pediatric patients, we should keep in mind that at times acute symptomatic or provoked seizure may gradually merge into epilepsy and in front of us, and very, very gradual. So we often see patients with viral encephalitis who are still into a recovering phase and eventually landing up in a chronic epilepsy condition. So at times the continuum is very, very evident in front of us, and where acute symptomatic seizures could be merging into unprovoked seizures. So commonly what we come across as provoked seizures are listed here, and the list can be really endless. But I have just tried to touch upon that something, which we shouldn't be forgetting is metabolic, glucose, obvious electrolytes, drugs, toxins, poisonings, other medications of other system, which sometimes can give provoked seizures. Oxygenation, blood pressure, simple things. Even patients with renal and endocrine disorders can come with hypertension and first unprovoked seizures. So there has to be a protocol whenever anyone is received with first unprovoked seizure, and a simple listing can sometimes give us a very good triage of how to get further. This is the last one of first unprovoked seizure. Are we really dealing with seizure? So anything which is paroxysmal and we are not able to define or classify it becomes a seizure. No, that's not the way we have to go about it. So as we can see that we can find many studies where they would have seen, like, how many non-epileptic paroxysmal events were counted as seizures. So 20 to 30% in this one of the series were misdiagnosis, and at times it can even be more. So something which is very, very important in history is event detailing or semiology. And when we say event detailing, it is really starts from how is the child's development, what was he doing, what was the setting, what was the time of the day, and are there any provoking events. Analyzing home videos or CCTV is often very helpful, and especially school videos looking for syncope and for paroxysmal events and movement disorders, etc. And also home videos for nocturnal sleep events and sleep phenomena. Age is very important, as whatever paroxysmal nocturnal epileptic events or paroxysmal non-epileptic events we are looking at, age and development plays a part in it. This is just a list, but I should say this can be very, very exhaustive. Just to name a few which are very, very characteristic in that age group, like in newborn, hyperekaplexia, jitteriness, and benign neonatal sleep myoclonus. In infancy, breath holding spell is something which could be very common in pediatric OPD. Shuddering attacks are equally known and something which we should be aware about. Stereotypies can be common in children with normal development or someone with developmental delay as well. Coming to the adolescent group, syncope, of course, in school-going children is something which poses a lot of difficulties at times, and we have to analyze it really well to say that are we dealing with seizure versus syncope. And very, very good diagnostic, dichotomies and algorithms have been mentioned for syncope. Tics and psychogenic crises are something which, again, in adolescent group, we have to look into and we have to keep in mind. Sometimes paroxysmal non-epileptic events can actually mimic a particular seizure semiology. And I'm sure all of you would have seen this. Like syncope can practically look like anything, like absence, drop attacks, or myoclonic. And in fact, in a later on anoxic phase, breath holding spell and syncope can look like tonic-clonic seizure as well. And of course, the migraine can be one of the paroxysmal non-epileptic phenomena, which may mimic occipital or temporal lobe seizure. Sleep disorders can look like frontal lobe seizures or Rolandic seizures. So whenever we are suspecting any paroxysmal non-epileptic event, it is a good idea to see, like, what semiology it is matching. And obviously, then these algorithms or knowing a particular disorder in that age group can help us tremendously. I just want to share a few of those here just to tell ourselves that how we have to keep our eyes open. So you can see this first video. He's a 2-year-old toddler and he has motor delay and on a routine follow-up. And this is the home video which was shared. So it looks like he's nodding, dropping his head, almost like a head drop, which is happening in cluster. And something which is a catch is later on, if you see, he is stopping and looking at in front in one of the parents. So in fact, the mother said that he is mimicking butterfly yoga, which one of the parents was doing. So you can imagine that something as weird as this and can look like a very grave seizure phenomena. And look at the second video where he is a 12-year-old. He does have stressors in terms of exams, not doing well in school. And you can see this is what he was doing. So turning his head to the right, something which if you only listen to the history can easily look like a partial seizure. He stops talking, he goes towards right. And when you look at it more carefully till later on, he has suggestion, he has pain on face, he's fully aware, and he's trying to do it. So this is how we can differentiate an epilepsy versus non-epilepsy if we go really into a good detailing of the video or events which we are seeing. I'm just playing all of these together in the interest of time. So, you know, these are shuddering attacks. A typical 1-year-olds, 1 year to 12 months olds. And we can see their shudderings are totally different. The first one is almost like myoclonic or jerking. This one had more left side. So whenever they were describing, it was like, you know, left side jerking. And this is almost behaving like a tonic seizure-like phenomena. So what I want to say here that something which is as simple as shuddering attacks in normally developing children can look like any type of seizure if we don't really look into it in terms of development and other presenting features. So yes, after all this, if we know that it is seizure, it is first and it is unprovoked. So we have passed all the hurdles and we know that we are moving towards the gray zone. So are the levels possible? Are we able to classify the seizure? Are we able to say that this is epilepsy or epilepsy syndrome? Do we have an etiology which is upfront, or do we need investigations? So once we have done all this, we know that next comes to us is treatment decision, counseling and preparedness for the events or ER access and do's and don'ts. So single seizure, can we call it an epilepsy? This was the gray zone which I was highlighting. Probability of further seizures similar to the general recurrence risk after 2 unprovoked seizures occurring over next 10 years. So this is what is the gray zone, which is left to the assessor, which is left to the physician, that how do we decide that though this patient has only one unprovoked seizure, but he still has the risk of 2 unprovoked seizure. So let's see if do we have anything to go by the literature or how we calculate the risk. Something which we have to do really adequately is a focused examination like any other case. So microcephaly, dysmorphism, syndromic, nutritional causes, even B12 deficiency, hypocalcemia, ophthalmic evaluation, hearing, looking at neurocutaneous markers more closely. So any epilepsy or a seizure case, these are whatever have been listed here is bare minimum, which we have to look at it very closely in general examination, skin and skull. Also nervous system examination, something which we have to be specially focusing at is focal deficits and asymmetry. Development, school performance, behavior, learning disabilities, ADHD, cognitive lag, all this always should be a part of epilepsy evaluation in school-going children. So development, focality, neurocutaneous markers, obvious dysmorphism, ophthalmic and hearing issues, if there are any, those should be noted other than handedness. As I earlier also I mentioned very clearly that all epilepsies start with first seizure. So it is totally up to us that which seizure we want to really refute and don't want to call it epilepsy. So it is of value to consider the nature of the underlying disorder in a patient who presents with first seizure, regardless of whether the diagnostic term epilepsy is applied to the patient at that time or not. That means we have to keep in mind that the same patient, maybe after a few months, we could be labeling as epilepsy. So we should try our best to say that whether this single seizure is epilepsy versus no epilepsy. This is a very good study, I should say, which is published in 2008 and which is an excerpt from MES study. So which is where they have tried to see that what happens to a patient after first unprovoked seizure. And really a large group of patients where all ages were included, including the seizure types and epilepsy. So this is what we can gather from there, that most of the untreated patient, 40 to 50% recurrence within first 2 years. This is where we get the idea that no need to treat really someone who has first unprovoked seizure, because we don't expect 50% of them to have another one, right? And treatment may reduce this risk by as much as half. So anyone who has more than 2 seizures will come in this category where most of them will be treating, all of them in fact. So the ones which are greatest risk of recurrence, the ones who have abnormal EEG, the ones who have identifiable neurological condition. So in fact, the abnormal EEG and abnormal neurological examination and identifiable neurological condition is the most important predictor for the risk of recurrence. So any patient who has these 2 conditions and has first 2 unprovoked seizure, those are the ones where we should be discussing, contemplating further investigation and also the treatment. Status epilepticus, though it looks very, very disastrous and catastrophic, may not have really increased risk of recurrence compared to patients who have just had seizures, not status epilepticus, but something which we have to keep in mind that these are the patients who are more likely to have future status epilepticus. That means if they have recurrences, there are good chances that they can have another status epilepticus. So the recurrence risk though remains the same, but the recurrence could be in the form of status epilepticus, which may really tilt our decision on the treatment side at times. So 90% of first unprovoked seizure attain 1 or 2 year remission within 4 to 5 years of initial event. And 80 to 90% individuals who recur will do so within 2 years of initial seizure. This is an important statement, because the moment we say someone who has unprovoked seizure that possibly you don't need a treatment, definitely they would like to know that for how long this remains on us, that like, you know, that I can have a second seizure and I can still become patient of epilepsy who is like, you know, treatment valid. So a 2 year guideline is really good, where we can tell them that in next 2 years, if you remain fine, the chances are really less that you will have another seizure. So this is the study which I was talking about. Something which I would like to emphasize here again, that normal EEG and normal neurological status is the lowest risk group. 20, 25, 30% of this group had seizures after randomization at 1 year, 2 year, and 4 years after randomization. So that's like really low, 20, 25, and 30. And the hazard ratio for neurological disorder is 1.35, and whereas hazard ratio for abnormal EEG is 1.54. That means while we are deciding on that gray zone, these 2 pointers are really important. Coming to the age, there is one study where they say in pediatric age group, the chances of once you have unprovoked seizures, the chances are slightly higher compared to the adults. The reason could be that they can be having, you know, more symptomatic group versus other side. So this is something which is a nice paper in Lancet Neurology, which is again drawn from MES trial itself. that where they have tried to say that what could be a prognostic index, and can we say someone that though you had only first unprovoked seizure, what are the chances of you having a next unprovoked? So if you have had only one seizure prior to presentation, your prognostic index is 0. 2 to 3, it is 1. 4 or more seizures, then it's 2. And look at it like, 1 is being given to each one, like abnormal EEG is 1, neurological disorder, deficit, learning disability, even developmental delay is 1. And when we sum it up, we can see that low risk is 0. So practically that means if you have only seizure, which is 1, and nothing else, then you are very, very low risk. Medium risk is only 1. That means if either of the 1 is positive, we can call this medium risk. And rest comes in high risk. So this is something which is a prognostic index which is being given. And obviously, I mean, there is something which should be more concrete and we should be awaiting for evaluating first unprovoked seizure. When it comes to investigation and how a first unprovoked should be investigated, obviously, I mean, we have to see what setting we are seeing these patients in. Whenever we are in ER, we are more likely to see these patients as acute symptomatic seizures. So obviously we need to do blood pressures, glucose, calcium, labs, infection, workup, and imaging, which can be more on the quicker side. So that we know, are we dealing with acute symptomatic seizures and it is not truly unprovoked. When we are looking in the OPD setting, we know that possibly the acute setting is not there in such cases. So meticulous history, examination, EEG, and then deciding on neuroimaging depending on which area, geographical area we are from. And if it is more NCC prevalent area, then CT scan is still recommended at places, institute to institute. If we have to do imaging for epilepsy and focal epilepsy, then MRI brain is obviously more superior to give us more structural details. Coming to the metabolic investigation, 2 metabolic disorders which we have to keep in mind and can present at any age. One, especially the pyridoxine dependency, especially in early infancy, toddlers, and early childhood. So when we say metabolic, at least 2 should be in our mind. And genetic, of course, should be discussed more on case-to-case basis. When we come to the EEG, which is of course first and foremost, which we order the moment we are saying epilepsy or epileptic seizures or first unprovoked seizure, and it holds a lot of value. And obviously the type of EEG which you are doing, the timing of EEG, and the EEG reading, the whole thing, it does matter a lot. But what are we trying to do when we are doing one optimized EEG is knowing the caveats. That means a single EEG, is it awake or asleep? And have it been ordered in a proper setting? And obviously an abnormal EEG, which is showing a focal epileptiform activity or even generalized, is a good predictor for recurrence risk of unprovoked seizure. And again, when we say focality in any patient, we are looking at 3 things. One is the clinical focal neurological deficits. 2 is on EEG, is there a focality? And number 3 on MRI or neuroimaging. So obviously EEG is one more localizing tool for us when we say we are dealing with focal seizure or focal epilepsy. And epilepsy syndrome, as we know, that they are rightly called electroclinical syndrome. So if we want to say that whatever we are dealing with is an A, B, or C epilepsy syndrome, EEG is obviously helpful, and that will kind of complete our diagnosis. So EEG is of a lot of value. Timing should be first 4 weeks. Most of the advisories will suggest within first 4 weeks, depending on the availability, facility, and also the workload on the centers. In children, sleep deprivation and also In focal epilepsy and generalized also, the sleep deprivation can improve the yield. Ordering a complete EEG, giving a background information, optimizing the EEG process can improve the yield to a great deal. Because as such, with overloaded system and limited resources, if a single study is able to give us a good idea, that is what we should be attempting at. And we should also know when not to order an EEG. So obviously breath holding spells, febrile seizures, acute symptomatic seizures where we have the cause, it's not a great idea to get an EEG done, because interpretation, also the implications related to whatever abnormality we see, will be difficult to explain or also to prognosticate. Coming to the neuroimaging, which is the next most important investigation which we add up to. As I said already, the focality is the important thing. If we are getting it on history, EEG or examination, neuroimaging should be done. And ideal should be an MRI, which should be a good resolution and preferably epilepsy protocol. That means 1.5 Tesla and above, looking at temporal lobe. And also for cortical dysplasia, focal cortical dysplasia, to have inversion recovery and the protocols which should be completed. MR spectroscopy, if we are seeing something which is lesional, or we are looking at tumor, or we want to look for gliosis. Something which, if some patient is showing kind of pseudo-refractoriness or not responding to treatment, or if the patient has developmental delay or learning issues, then also neuroimaging is something which will add up to our complete diagnosis. Finally, after the workup, we have first unprovoked seizure, or we have diagnosis of suspected epilepsy. We have optimized investigations in terms of EEG and also imaging. So the patient should be treated with anti-epileptic or not. As I said, with first unprovoked seizure, it is the recurrence risk which should decide. Are we on to a diagnosis of epilepsy syndrome, and how is the natural course of that epilepsy syndrome? So treating a patient with anti-epileptic in a patient with only first unprovoked seizure with a higher recurrence risk calculated, we have to discuss it with the family, and obviously we have to weigh risk versus benefit, because all this two or more has come from the whole idea that anti-epileptics can give a lot of side effects, and they can be, it is a long-term treatment, and also the economic and financial burden. So whenever we are deciding on any long-term anti-epileptic, there has to be risk and benefit calculation on those case-to-case basis. As we will be aware, whenever we are weighing anyone in terms of treatment, what are we looking at? So we are trying to reduce the seizure recurrence risk, especially if the patient has risk of status epilepticus, and long-term remission we are looking at. So the patients who have chances of having more recurrences, then definitely they will benefit with this long-term treatment. And also now, since we are discussing a lot of sudden death in epilepsy, SUDEP, and reduced risk of death, so patients who have had tonic-clonic prolonged seizures, it can be these are the patients whom we at times try to err on the side of treating. And obviously risk also have to be discussed on case-to-case basis, based on their age, based on their comorbidities, and also the medications which will be used, longevity, any organ-specific side effects. All those have to be discussed in details with patient, caregivers, and family. How long to continue with the treatment? So this is something which I feel is not really actually proper to discuss here. But whenever we say we have initiated treatment, it will always come the question, if there is a patient with first unprovoked seizure and we have initiated treatment, then obviously we have to know that what type of epilepsy it is this is asymptomatic or there is a structural cause. how long we want to go on for treatment on this patient. So the moment we have a concrete diagnosis, the following questions are like, the clarities is automatically in front of us. Like we know that most of the epilepsies, the treatment is preferred for over 2 years, and it is known to lower the number of relapses. And patients who have more chances of seizure relapse are the ones who are on polytherapy, or if they have abnormal EEG on drug withdrawal. So frankly speaking, how long to continue totally depends on the type of epilepsy syndrome, etiology a given patient has. And most of the pediatric epilepsy and epilepsy syndromes are so unique that they have to be discussed on case-to-case basis on a given case. But in general, the general rule to follow is a 2 years period of seizure freedom. This is an AN practice parameter. As I was saying, that most guidelines what we have, in nutshell, what it gives us, this is a 2003 practice parameters, which is still holds true. Number one, treatment with anti-epileptic is not indicated for prevention of development of epilepsy. That means if we have only seizure, then it is a level B evidence that we shouldn't be treating it, and it is not preventing development of epilepsy. We don't know when do we change this. Number two is treatment with AED may be considered in circumstances where the benefits of reducing the risk of the second seizure outweighs the risk of pharmacological or psychological side effects, which is level B. So this is almost what we are trying to do when we calculate recurrence risk and optimize treatment or predict the future course in a given case. Something which we should never forget is whenever we are leaving a patient of seizure and who's leaving our OPD or clinic, is to tell them what happens if they get a second seizure. So do's and don'ts, whether in the form of pamphlets or whether in the form of posters or a soft material, and it should always be given. So giving patient the adequate information is very, very important, whether it is done by a nurse or the physician himself. So they should be told this basic do's and don'ts about handling during the seizure. What happens if the seizure doesn't stop within 5 minutes? How to give emergency medication? What doses are available? Are they adequately being explained? And for a given weight, are they readily available? When to visit an ER or call an ambulance? So domiciliary seizure control have to be mentioned in any patient who has presented with true seizure. So buccal or nasal midazolam is something which is freely available and should be ideally be demonstrated to the patient how to use it and what doses to be given. And a rough calculator is for 0.5 milligram midazolam doses, that for 10 kg, a total of 4 puffs, and for 30 kg, total of 12 puffs. So it should be a ready guideline which should be there with us so that exact doses and procedure and process is explained to the patient. Recovery position should always be explained to the parents that after the use of immediate measure like midazolam, or even after a seizure which has spontaneously stopped, how to give a recovery position on a child or infant have to be explained either by demonstrating or by showing posters or papers. So something which we can see here very clearly, how should be the left side and how the infant has to be rested. So something which is shown is always practiced better. Lifestyle, safety, driving, sports, what happens to their schooling, education, etc. has to be explained even when we say someone we are coming across who has had a single unprovoked seizure, because obviously these are the patients where we may contemplate that they could be having a second unprovoked seizure, though the chances are 50% or less, but still they should be given advice on the future course as well. Coming to the summary, and this is the final slide where I just have a recap that when we say first unprovoked seizure, please try to prove each and everything in the given phrase. First, unprovoked, and seizure. All three have to be looked at it really, really carefully. After we have done this, do we have a recurrence risk prediction on a given case? Do we know that this patient could be having recurrences, and can we predict that this patient can be treated as epilepsy? Accordingly, investigations in terms of EEG and neuroimaging. Are we reaching epilepsy and epilepsy syndrome in terms of a diagnosis? And finally, planning a long-term treatment, giving family, patients, school advisory and education on handling, suggesting them follow-ups, how it has to be. Also, the emergency measures have to be explained and demonstrated well. So I end this here. Thank you for your attention. Thank you for your attention.
Thank you, ma'am. Thank you for this comprehensive and a very practical approach to the first unprovoked seizure. We're very thankful for your presentation. Now I start the discussion on this topic. I now request our chairpersons to offer their comments and questions, if any.
Thank you very much, Rashna. That was a very nice practical way of how to approach a seizure in the emergency room or in the OPD, and how to sort of take the thing forward. The only thing I have a question, or a comment and a question in one, is that, you know, the figures are not, when you say 60% and 30% and 40% and all that, it requires a certain amount of education and certain amount of, you know, your parents should be able to understand all that. And that's what I find in my practice, that, you know, in America and other places, they sort of give the information and then the decision is taken by the parents, you know, what to do in that particular situation. Over here they say, "Aap bataiye kya karna chahiye," because that is what everybody wants us to decide. And obviously that is not a correct thing, because these are important things which need to be having at least bilateral discussion. So I really have a problem with this, how to sometimes the anxiety of seizures, especially, you know, is so terrible, and the parents undergo a lot of stress, that even in a patient who may not really require treatment, sometimes you're forced to give it. Or this is one of the problems. How do you deal with it in your practice? This kind of, you know, how do you explain counseling to the patients, especially the ones who may not be, you know, educated or whatever it is, to understand the meaning of risk of recurrence?
Yes, sir. So this is what actually, you know, I have quite a bit emphasized on this. Like, you know, this is the gray zone and gray area, and which is totally left to the clinician. So it's basically, it's on us. So I agree what you are saying, and we commonly face this, especially with benign or self-limiting epilepsy syndrome, where the guidelines clearly will say that, you know, these are infrequent and they will be self-limiting and they will remit on their own. And counseling the parents is a big issue, because the moment they see anything convulsive, anything which is tonic-clonic and lasting more than few minutes, they will say, we don't want to see it again. Yes, this happens very often, and especially with our parents and our community. And they don't mind treatment. Actually, they don't mind treatment. In fact, in the Western world, they will say, do anything, we don't want treatment. And here they will say that we want everything, you do everything, we don't want to see this again. So this is the dilemma which we see, right?
The more educated you are, the higher socioeconomic group, the ones who don't want to treat, and the ones who are lower socioeconomic, less educated, want to, you know, do it. Abhi bataiye kya karna chahiye. So that's a big problem, really.
And also one thing can be that, like, you know, if we empower them more on how to handle it when it happens, they are more confident. And something which I always do, and I find it useful, is having a mannequin and showing them that what you have to do. So I have 2 dolls with me and I show them. I don't leave it to the nurse because I don't know what she will be telling them and I have no control over it. So telling them exactly that this is how your spray is, this is how you will open, this is how you will give, and this is how you'll handle it. And also telling them how long the seizures may last and how it is not affecting your child's intelligence. And so especially the epilepsy syndromes where we can predict, it is easy to convince and counsel them. And obviously the final decision remains theirs. Something which I have learned over a period of time, that initially when we were just writing and I was not demonstrating them, almost 40–50% of them had acute measures to handle, but they were not using it. They were fumbling, they were dropping their nasal drops and all that. And they will be like, we couldn't control it. So if we don't empower them, we don't have really a right to tell them like, you can choose treatment karna hai ki nahi karna hai. But if we tell them what happens if they see the second episode, then I guess we have better chances that we can convince them that we hold on the treatment.
Sure.
Thank you, ma'am, and thank you, sir. Dr. Pandian, sir, for comments.
Yes, madam, that was a lovely lecture. And I always feel I am the third consultant because the decision is easy. I just want to know which is the type of seizure you will not hesitate in starting drugs straight away. Because some of those times parents will tell you, doctor, you tell me. If I have to give, I'll give. So that's a very difficult situation to decide. Which are the types of seizures you don't hesitate to start anticonvulsants, recommend anticonvulsants straight away. Leave alone the EEG criteria, MRI criteria, neurological criteria.
I guess whenever, this is what I was saying when I said, the moment you see JME, the moment you see absence epilepsy, we know we have to treat them, right? So even though they would have come, we have seen it only singly or right now only, we know they will be the ones who will need treatment and they must be happening multiple times. So in terms of epilepsy syndromes, JME and absences are upfront, which need treatment the moment you see. And when you say the type of seizures which you would like to treat or epilepsy, then obviously in our country, we still have a lot of patients who have structural causes, perinatal insults. So someone who has had a focal and a prolonged seizure with perinatal phenomena, perinatal events and ICU stays, those are the ones where we need not be very, very we have to have little pragmatic approach. So those are the patients where we can say still we could err on the side of treating, like patients who have history of neonatal encephalopathy, hypoglycemia, hypoxia. So anyone who has had any underlying neurological condition, I guess they merit treatment even with first unprovoked.
Dr. Udani, sir?
Yes.
What is your experience of recurrence of focal seizures?
I think, it's the type of seizure doesn't necessarily mean that it's going to recur more or less. It depends on the syndrome. For example, in the self-limiting focal seizures, the recurrence risk is low. While the same patient, you might have a lesion or something and may look like self-limiting, but the MRI tells you different, the risk is higher. So I think it's a question of the type of epilepsy. And I think she's, very, very nicely stressed how important it is to try to come to a diagnosis, after you confirm it's a seizure and all that. For example, many generalized seizures, especially in adolescents. So it really depends on the age, when you see it, what type of background there is, and then, you should sort of take the whole thing. And I agree with her completely that if you have status, if you have lesion, or if you have then the might as well treat. The other problem which I'm sure you face and Rachna also faces is that many of them come to us when the decision is already made. Somebody's already started the drug 3 months ago, 4 months ago, so then you're in a problem. It's not really. Then they come and ask, now what should I do? Now, should I stop the treatment? That's a real difficult question to answer.
Thank you, sir. Professor A.V., sir, for comments and questions, if any.
Good morning, Professor Kumaresan, sir.
Thank you, madam, for the great lecture you have given today. In one of the slides, you had shown about the prediction of risk of seizure recurrence, prognostic index. Do you follow it? And if the medium risk case is there, do you advise anticonvulsants? If so, for how long?
Not really. I mean, this is not as concrete that we can follow it, as a guideline. What I'm trying to say that we do have something like this which exists in literature and which is kind of giving us a way forward. We all know that unprovoked seizure means, yes, this is an epilepsy substrate, and maybe tomorrow 50% of them we could be calling an epilepsy. So why, shrug away ourselves right now today? It is like, passing the buck on the second event. So what I'm trying to say here, that when we say first unprovoked seizure, are we able to get some idea, like, where are we? Where are we in terms of 20% recurrence, 50% or 70%? So that is a very nice paper. Maybe, I'm sure, I don't know whether in future we can have something which comes up more concrete. But yes, I mean, something, if I have to draw an analogy from that paper, so if I see someone who has occipital gliosis, who has developmental neurological deficits, I see changes on MRI, I see a focal EEG and has come with first unprovoked seizure, quite likely this patient will have reasonable recurrences. So those are the patients where you could really see, you can calculate the risk. And obviously it goes in epilepsy definition as well. So it's good enough to initiate treatment on that. So it is no crime really to start treatment, especially if you are able to establish recurrence risk and you're able to calculate in a given case.
Thank you, madam.
Yeah.
And one more question I have. The EEG, you take it immediately after the seizure, or you take it after 2 weeks or so?
Unfortunately, I mean, if you ask my particular practice, then most of the patients who have had unprovoked seizures are visiting us in 3-4 weeks only, unless we have patients who have acute symptomatic seizures where EEG may not have much value. You have many other things like, which should be done. So frankly speaking, most of the centers and most studies will tell us that up to 4 weeks is also fine. So I don't think there is too much to fight about it, especially when it is epilepsy syndrome. You can diagnose it whenever you do an EEG. So electroclinical syndrome, more problem is when you're talking about focal epilepsy or focal seizures, where the timing becomes an issue. And even up to 4 weeks should be perfectly fine. So we don't really try to push the system for an early EEG. No, not really.
Thank you, madam. Thank you, Shiva.
Thank you, ma'am. Thank you, sir. We are also joined by Professor G. Kumaresan, sir, who was the former head and Director of Pediatric Neurology in the Institute of Child Health and Madras Medical College. He was the first pediatric neurologist in this part of India. We are happy to have you here, sir. Welcome, sir. If you have any questions or comments, you can ask.
Thank you so much. Beautifully organized. All the best. Let things. I will not miss even one of your series. It's beautiful. Beautiful.
Thank you.
Congratulations to the speaker also.
Thank you, sir.
Thank you, sir.
Hello, Professor. How are you?
Thank you.
Thank you, sir. Thank you.
Now I request Dr. Thangavelu sir and Dr. Mahesh sir to just start the Q&A session. We have a few questions in the Q&A and chat box. I also have received a few questions by mail, so I'll quickly post them. And I think Thangavelu sir will be the first to start, and the panelists are free to comment and give their opinion on questions.
Thank you, Shivan. Madam, it's a wonderful talk. Lot of practical hints. And I just start with the first question. Is myoclonic seizures and astatic seizures are classified under unclassified? Myoclonic seizures and astatic seizures, are they classified under unclassified? That was the question.
Myoclonic seizure is classified under generalized and astatic as well, because the onset is generalized.
Second question is, can the terminology status epilepticus be used in neonates? Status epilepticus terminology, can this be used in neonates?
Yeah, this can be used in neonates, convulsive versus non-convulsive, and EEG criteria and others. For neonatal classifications, as I said, the semiology-wise, the newer thing which have been added up in terms of sequential seizures and the seizure pattern, whatever we are seeing in terms of classification is not same as what we are seeing in today's presentation. So neonatal seizure classification by ILAE, which is being led by the UK and the French team, will be soon available, and it's already there for peer review. So I'm sure that can be assessed too.
Next is an interesting question. Are the involuntary urination and defecation during some paroxysmal episode, for example, a child with breath holding spells, so uncontrolled urination and defecation, does it amount to classifying them as seizures?
No, not really, because any terminal anoxic event, which can happen with syncope or breath holding spell, can have tonic-clonic phenomena and can have urination and defecation. And this is more part of anoxic phenomena which they are having. So urination, defecation is not really important when we have to say epilepsy versus no epilepsy.
And a question to this is particularly when the EEG shows an epileptiform discharges. In this child,
this will be very difficult. This is what I emphasize when I say when not to do an EEG. So we know that up to 5% of normal people can have paroxysmal activity on EEG. Even developmental disorders and normal. So when we are saying patient A doesn't have seizures, then it is not of value to get an EEG done. The moment we say this event is breath holding spell, I guess EEG is not valid on that particular patient. And even if we have done it, and if we see that it's showing something, I don't think we can treat that EEG. We'll have to wait for a seizure. Because many patients who have epilepsy syndrome and true epilepsy, they will keep showing epileptiform activity after our treatment is over and they remain seizure free. But we don't reinitiate treatment on them just because we are seeing something on the EEG.
Camphor poisoning presenting with the status epilepticus, Shigellosis child presenting with status epilepticus. Do they need long-term anticonvulsants?
Any acute symptomatic seizure, which is could be related to encephalopathy, HUS, or hypertensive encephalopathy or anything. So most acute symptomatic seizures should be treated till that acute symptomatic condition is there. So long-term treatment is valid only for epilepsy or ongoing seizures. So as I had tried to emphasize here, that viral encephalitis and Fire syndrome and neurocysticercosis are 3-4 phenomena where the continuum is there. That means you have little merging of acute symptomatic into epilepsy. But any other encephalopathy or encephalopathy related seizure should be managed as acute symptomatic seizures till we see unprovoked seizure.
There are many questions. Even though you have explained about the timing of EEG, you said no, up to 4 weeks. That is up to 4 weeks. In a hospital with a pediatrician and pediatric neurology, they come on the first day itself. So are you going to postpone till 4 weeks? Because when the child comes to you at 4th week, you can even do it. But when they come earlier, first day, second day, so how do you fix the timing of EEG? Will you do it in all unprovoked seizures? All first unprovoked seizures?
All first unprovoked seizures, yes. If they are we are telling that this is first unprovoked seizure. It is, if it is available, yes, it is always a good idea to get an EEG done. When it comes to the timings, I don't think really it's a good idea to fix this. But when we are doing it in 48 to 72 hours, we may see more of slowing and more of drug-related events and effects. So something, which is available to us only once maybe, or we don't have luxury to repeat the EEG, then the timing has to be important. So it is better if it can be deferred so that, we can see the true epileptiform phenomena. that is how I will address this.
Can I presume that it is probably after 3 days or 4 days to
Yes.
whether drug
Yes.
effect and other things? Thank you,
Yeah.
madam.
Yeah.
And how common is SUDEP, that is sudden death in epilepsy? How common? Because we have not, general pediatrician, we don't come across. Because this is being discussed often in neurology forums. I'm a little worried how common it is. Who is at risk?
See, basically, SUDEP, when we say, like, how common it is, whenever we are talking about SUDEP, generally we are discussing in cases who have pharmacoresistant epilepsy. So patients who have channelopathy, patients who have Dravet syndrome, patients who have early infantile epileptic encephalopathy, they are the ones who will have multiple seizure types. They will have prolonged tonic-clonic or autonomic phenomena associated with seizures, and the cases with SUDEP. So unfortunately, when we say in our scenario, I don't think we have studied it enough. But if we have to draw conclusion from what the other population and other Western world has done it, yes, it does exist. And yes, we have to talk about it more often, and especially patients who have frequent tonic-clonic seizures, and the patients who have more of developmental encephalopathy, who have tone abnormality, who have developmental issues. So those are the patients who can face SUDEP. And it's a real thing. Of course, it's a real thing.
A child on anticonvulsants coming for fever, cold, cough. What are the drugs the pediatrician should avoid which are likely to reduce the seizure threshold? For example, I'm just quoting, antihistamines might reduce the seizure threshold. What are other drugs they should avoid in a child who is already taking AED, which is likely to reduce the seizure threshold?
Yeah, things like quinolone and quinine, quinidine. Obviously, we are not using it that often. So quinolones are the ones, and also the ones which can give interactions like macrolides and others, because many anti-epileptics can be enzyme inducers like carbamazepines and others we are not using. So I guess it's more of drug-drug interaction, but when we are using it short-term, it may not be that much valid. So drugs like phenytoin, carbamazepine, where drug interactions are important, we have to keep those in mind. And also when we are giving valproate and others, where the platelet and bone marrow suppression, those things have to be kept in mind, especially patients who are in ICU, who are on multiple drugs, and could be having unexplained hematological phenomena and others, bleeding diathesis, etc. Especially when we see patients who have dengue, and already an epileptic patient comes to us with dengue and low platelets on valproate. So that may not be an uncommon situation which people come across. So we have to see the adverse event which could be related to that febrile illness or that viral prodrome or the viral phenomena, and taking care of that drug-drug interaction, whatever drug you are using.
This is about an individual child on treatment. A child with ADHD on AED getting clobazam, no seizure for 3 years. Can we taper and stop? That was question asked by ADHD on AED clobazam, no seizure for 3 years. Can we taper and stop?
Obviously, as I said, for the treatment duration, the best guide is what type of epilepsy and epilepsy syndrome we are looking at. Is there any structural substrate? And if all that is there, how is the EEG and overall phenomena? So all these things will decide when to ideally taper anti-epileptic. But it's a rare situation where clobazam will be a monotherapy in a child with ADHD and epilepsy. So this overall scenario doesn't look very matching, right? Because most children who have behavior hyperactivity issues, I don't think will be given only benzodiazepine to control epilepsy.
Thank you, madam. Can you repeat the dose of midazolam nasal spray?
Yeah, so 0.2 milligram per kg per dose. The spray, what is available to us, which is like, the brands which are available are Insed, Midasep, and Medistat, which are 0.5 and 1.25. So most children who are up to 15 kg, if we say that for 10 kg, we are using 4 puffs. For 15 kg, it will be total of 6 puffs. For 20 kg, it will be total of 8 puffs. So if we say 4 puffs, then we can tell them 2 puffs each side. If we say 6 puffs, it's 3 puffs both the sides. So 0.5 has to be prescribed for someone who's up to 15 to 20 kg. Beyond that, 1.25 milligram one will be better. So especially a child who's 30 kg, 40 kg, then you can use 1.251, 3 to 4 puffs, total 3 to 4 puffs. Because the moment you start crossing 10 puffs, it is kind of aerosol. So start getting mystified and start stacking down. So you have to choose the appropriate preparation for the weight. For the younger patient, less than 15 kg, 0.5. I'm sorry, I didn't emphasize it more. I guess I should have more detailed.
I have a big concern. Did you encounter any serious complication following usage of these sprays, like death? Because
I haven't.
One of our colleagues experienced that.
Right. So, if we are not explaining it well, it may happen. Because what happens the moment we have used midazolam nasal spray, these children will be floppy and they won't be breathing well. So maintaining an airway after midazolam nasal spray is very, very important. And most of the Indians are very, very used to, placing our children flat on lap. They will place them on lap or something straight, and the moment you are placing someone straight on the back, you are making them hypotonic, tongue will fall backwards, and there will be an obstruction to the airway, and that may lead to hypoxia and such events what you are describing. So it is very, very important to explain the correct dose, to check their medications when they're coming. So those are the checklists which have to be done for any emergency explanation you are giving them. When we are doing any emergency procedure, our nurses, our nursing staff, and even doctors are trained on mannequins and all. How can we expect a parent to be doing it rightly when this catastrophe is happening suddenly in front of them? So it's always a good idea to train them well and teach them in front of you, make them do if you find them shaky, and ask them again that how will you do a recovery maneuver. So all this helps over a long run. All this helps. They are more confident and they can do it better.
Thank you. Next is a very practical, simple clinical question. I used to have doubt how long you can allow the post-ictal drowsiness, and beyond which you really worry why the child is not recovered after this. We are given 2 dosalorazepam, seizure control, the child is sleepy. How long should I wait to think to the further step?
So it will have lot of I should say predictors. So have we used benzodiazepine? Have we used lorazepam? Have we used multiple doses of midazolam? But mostly if a seizure has been brief, not into status epilepticus, then most of these patients should regain consciousness or becoming to, towards the normal sensorium side within an hour. So beyond 1 hour, if they are unarousable, still into encephalopathy, then we have to look into electrolytes, drug overdosages, hypoxia, and other things.
So concern after
concern
after 1 hour.
Yeah.
Last question from my side before Mahesh takes over. This is something like a catch question. This is a 4-year-old child, first unprovoked seizures. But mother comes and says that he had a simple febrile seizure 2 years. 2 years simple febrile seizures. 4 years first unprovoked seizures.
Right.
So how do you proceed for this situation?
I got it. So I guess you had last Friday very, very exhaustive lecture on febrile seizures. But yes, let me comment on this. Anyone who has history of febrile seizures comes to us with a febrile seizure.
Yes.
Yeah, so we have to see whether we are dealing with something like febrile seizure plus. Are we dealing with generic epilepsy with febrile seizure plus? So a family history is very important. How is neurological development of that patient? How is the perinatal history? Is there history of any postnatal event, hypoglycemia, hypoxia? Because it's not uncommon to see children who have perinatal brain injury and substrate inside, and they can come to us as febrile seizures and afebrile seizures. So we'll have to differentiate, are we dealing with a febrile seizure related syndrome, or are we dealing with something who has neurological abnormality on imaging, clinical examination, development, and now we are dealing with epilepsy. So yes, these are very, very important cases, and we see them very often because our NICU care is still not up to the mark. So we do have many such cases during the NICU stay who have had brain injuries related to infections, hypoxia, hypoglycemia, and they come to us as structural epilepsies later on, and they can have febrile seizures in the beginning.
It's a little unconnected question.
Yeah.
Yeah. 1-year-old child presenting with unprovoked afebrile seizure, unprovoked seizures, suspected to be generalized because mother could not identify any focality. CT showed a ring enhancing lesion. How younger you have seen tuberculoma and neurosis, youngest age you have seen? 1-year-old unprovoked seizures presenting, and focality was not identified by the mother. The presumed a generalized convulsion. CT showing a ring enhancing lesion.
Yeah, ring enhancing lesion if it is single. Right now, if your radiologist is very well versed, it is not really difficult to say which is NCC, which is MRI. So I really don't find this much of a difficulty to keep calling it TB versus MCC. No, it can be sorted out if we discuss it well with the radiologist, or we can have our own inputs. So yes, even 1-year-old can have NCC, and coming with generalized seizures and seeing an active NCC. The moment you see NCC on imaging, we will see whether there is perilesional edema, in what stage it is. So if it is a colloidal stage, we have perilesional edema, we know the seizure must have come from there. And there is no reason to think of two things there, that the patient has focal lesion and he has another type of epilepsy. No, that's not done. Right? So one patient ideally will have one problem. And NCC can come as young as 1 year also in endemic situations. Yes.
Thank you very much. I request Dr. Mahesh or Shivan to take over the questions. I think we have some more questions.
Yes, sir. This is a question from Dr. Sasmita Agrawal. What's the presentation of cognitive and focal hyperkinetic seizures?
Can you repeat the question? I didn't get it full. Yeah.
What's the clinical presentation of cognitive and focal hyperkinetic seizure?
We are talking here to three things, right? So focal is the first start of point. So when we say seizure onset is focal, perfectly fine. So focal, then we can have awareness versus impaired awareness. Then I hear hyperkinetic. Yes, once we say in focal, motor phenomena can be hyperkinetic. What was the third thing? Cognitive or dyscognitive. Yes. So a patient who doesn't seem to be having whenever in a clouding of consciousness, that can be added up as dyscognitive. But when it comes to the glossary, which we have to use for seizure classification or describing a seizure semiology, we have to absolutely stick to the algorithm which has been mentioned. So focal comes much high up. And in motor phenomena, we'll have hyperkinetic, and in non-motor phenomena, we'll have cognitive, dyscognitive.
Okay, the next question will be,
just one point over here.
Yeah.
Cognitive could also be things like, feelings you get, deja vu, jamais vu, feeling of being there, aphasia, those kind of things. So you may have a cognitive that could be there as well.
Yes, sir. And next question will be that should we increase the dose of anti-epileptics in children during fever-provoked seizures and who are on anti-epileptic drugs?
I don't think that is a good idea because we know most of the anti-epileptics won't act at that short period of time, especially knowing their half-lives, etc. So increasing during the febrile period or infections, no, not a great idea. So any anti-epileptics which is going at an optimum dose and optimized should be able to control provoked versus unprovoked seizures both in a given patient.
Next question will be, Rolandic epilepsy is called benign. Does it need treatment?
This is a big question. So, self-limiting, now it is called self-limiting in the newer classification, because benign was giving us an idea that it is just one end of spectrum and all the patients behave in a similar manner, which is not so. Many of I shouldn't say many, but quite a good number of patients who have benign Rolandic or self-limiting centrotemporal spike related epilepsy can have behavioral cognitive issues, and at the other end of spectrum they can have severe EEG abnormalities as well. So obviously, when we are suspecting patient who has self-limiting Rolandic epilepsy, we have to look at their development. We have to look at their cognitive issues. Are there any changes? And a good follow-up is really, really important. And if we are on the one end of the spectrum, which are truly benign, looking at our clinical assessment, then yes, they don't need treatment. They don't need treatment.
And next question will be neuroimaging, whether it's needed in unprovoked seizures. I feel without that, we don't know. For example, neonatal hypoglycemia in most cases. Do we need neuroimaging in unprovoked cases?
In unprovoked seizures, as I had tried to discuss over there, whenever we have focality in clinical examination or in seizure, or the EEG also suggesting focality, and we are suspecting structural developmental issues, perinatal, neonatal events, then imaging is really helpful.
Okay. Next question already answered. If the child comes the very next day after the first episode of unprovoked seizures to the OP, what is the apt time to get a EEG done?
Yeah, we discussed that. We discussed that enough, and we can have even Dr. Udani's view on that.
Missed that. What was that?
So first unprovoked seizure and the timing of the EEG, if they come,
Actually, I'm not. I agree with you completely. I don't really pay much attention to it. Depends on how easy it is, because one of the reasons, one of the advantages of doing an early EEG is one that, because you may have though you may have slowing on one side, it'll tell you. You may not have all the established spikes because they get suppressed a bit. So I think within a week would be fine. That should be more. There's no urgency, but at the same time, the only urgency is when you're suspecting the patient is not getting up after a seizure, then you want to know whether he's gone to non-convulsive status. Otherwise, there's no urgency.
The next question. Whether Panay-Topoulos or Rolandic seizures are benign, then why to treat? Already partially answered.
yes. So Rolandic, I agree. But Panay-Topoulos and Gestalt variant of occipital epilepsy at times can be very, very disabling, not as infrequent as Rolandic. So I guess for occipital paroxysms, at times it is good to give treatment. I will have Dr. Udani's opinion also on this. And about Rolandic epilepsy, yes, that's right. That, if we are on the one side of the spectrum where we have everything clean, then it is self-limiting. And for infrequent seizures, the parent should be explained how to handle the next seizure, and the treatment can be on hold.
I agree with you. See, the Panay-Topoulos, the problem is very often there's a history of vomiting at night, and that may be actually missed, which you also mentioned in your talk. So you may not really have the first, it may not be the first seizure. Second thing is they very often come in sleep with long seizures. They can have, status epilepticus pretty commonly. So I think in that situation, very often, it becomes quite extreme, and that's why most people will start treatment early. But it's possible you could wait. It's not that you have to treat. Gastro, on the other hand, which comes later on, usually comes with migraine-like symptoms, and very often, again, it's missed as migraine. So you get visual auras and headaches, and then when the seizure comes, so very often that's also treated. So I agree with you.
Thank you, sir. The next question will be, does sedating the child during EEG can change the picture?
Yes. So whenever we are doing an EEG, most centers will have their own protocol for sedation and sleep deprivation. And it should be a written down protocol, because all patients who undergo sedation, what emergency measures we have to handle that sedation, what should be the doses, everything has to be mentioned. And the ideal thing could be triclophos. Melatonin at times we feel could provoke a seizure or something, so may or may not be. Sometimes patients who have lot of behavioral and cognitive issues, it could be really difficult to sedate them, where antipsychotic agents are also being used during the EEG procedures. And obviously, for obvious reasons, benzodiazepines are to be avoided completely, because they will reduce epileptiform phenomena and epileptiform activity. So triclophos, at times I have seen even promethazine, phenargon being used, and melatonin, meltofast, and antipsychotic agents in patients who have a lot of behavioral and cognitive issues.
Next question is it a good idea to start oral AEDs without loading on OPD basis, or loading followed by oral is preferable?
Whenever we have a structural, it totally depends on case to case. Someone who's presented with status epilepticus will be a good idea to give an IV loading at that point itself. But someone who has an epilepsy syndrome, which is ongoing and long-term epilepsy, starting off with oral anti-epileptics is perfectly fine. And totally depends on the seizure frequency and whatever type of epilepsy which we are looking at. So someone who's having really frequent seizures within a week, a few, then definitely giving an IV loading dose will give a better control. But for a single unprovoked seizure where we are encountering a status phenomena in the beginning itself, then obviously those are the patients which go on IV loading.
And next question is, what's the drug of choice in focal epilepsy?
Okay, so that is kind of a good question, because again, when we say focal epilepsy, the self-limiting benign epilepsy syndromes, especially the Rolandic, it's a good idea to give valproate, though it is focal, because sometimes, though it is rare, but even carbamazepine push it into more generalization and things like that. Otherwise, in patients who have structural focal, then more narrow spectrum medications can be used, like carbamazepine, oxcarbazepine, and others. And obviously, when we are not able to define that it's focal alone and other seizure types, then using more broad spectrum or valproate is better.
Okay, the next question is, will you start anti-epileptics in a child with first unprovoked seizures with background family history of epilepsy?
Okay, so family history of epilepsy or seizures is not really considered a recurrence risk, high recurrence risk in most of the studies. But yes, if someone is having family history of GME, absence seizures, where we know these seizures are recurrent, so it totally depends on that given patient, what type of seizure he has. Are we contemplating epilepsy or epilepsy syndrome, and what should be the treatment for that? So that is more important. Just family history alone is not really the criteria.
Yeah, and the last question, 7-year-old child had removed symptomatic focal epilepsy due to perinatal insult. He's on carbazepine, but seizure is continuing. So which other drug should be added?
Okay, so carbamazepine, it's not unknown that, like, that the drug levels, what dosages we are using, and at times they may go they may not be helping despite of adequate dosages. So these are the patients where levetiracetam can be used, or even valproate can be used. So not necessarily that carbamazepine, if it has failed, then levetiracetam or valproate also will be a good option.
So thank you, sir, and thank you, ma'am. Since we are running out of time, I'll just finish with a few quick questions which our postgraduates wanted me to ask you. There are many questions on non-convulsive status, but there is a separate session on status epilepticus. We'll discuss that there. So there are a few questions from postgraduates. Should the dose of anti-epileptic be increased with the weight of the child?
At least in first 2 to 3 years, when the weight and volume of distribution, so everything goes on the pharmacokinetics really. So in the first 2 years, then when the increment of weight is that much and we are trying to achieve, because otherwise it will become totally different than what we started with. But when mostly the weight becomes more on the stable side, it is not necessary to increase as per kg, and as long as the patient has good seizure control. So in a seizure control patient, not necessary. Yeah.
Thanks. So when the onset of a seizure is unwitnessed or the mother is not able to describe the onset, we are compelled to write whether it is a focal seizure or generalized seizure. Is there any other category we can use, or how to put it on paper?
Yeah, definitely. Like these are the ones where we write unclassifiable, right? So we still consider them as seizure-like phenomena seen, witnessed in post-ictal state, and we can write unclassifiable, right?
Unknown or unclassifiable is an accepted classification which postgraduates can write on paper. Another one, how to differentiate a myoclonic seizure from a spasm? Both look very identical. So are there anything clinical pointers to differentiate them?
Yes, definitely. So if you can remember the video which I showed you, the girl when she was having the jerking of the hand, which was like electric shock like and very, very brief. So it's fraction of second. So when we say electric shock, when we say fraction of second, it is more pragmatic way to call a myoclonic seizure. And otherwise EMG along with EEG is a good criteria. Epileptic spasms are definitely more than that. There are a few seconds, and tonic seizures are even longer than that. So it's all about duration. So myoclonic, epileptic spasm, and the longest will be tonic. Yeah.
Thanks. And the drug of choice for focal seizures, you've already mentioned oxcarbazepine or levetiracetam. For generalized seizures, which is a drug you will prefer? Will it be phenytoin or valproate or something else?
Valproate is a good option when we're saying generalized. Phenytoin, because of the monitoring issues and side effects and all that, is little low, but still we are using it in the public hospital setting, etc., and especially in the older. Yes.
All right. Thank you. This is the last question, which parents keep asking us. How much of screen time would you advise in children with epilepsy?
There is not really that I have come across a separate guideline for children with epilepsy, or photosensitive epilepsy will be a totally different issue at all. So 1 hour screen time, which should be like, more for entertainment type, because right now all their studies and everything is also on academics is on screen. So practically that makes it itself more than recommended. So 1 hour should be the total screen time, which includes everything actually.
All right.
Yeah.
But
Shivan, can I add one question, Shivan? One of the...
Yes,
arbitrary. Yeah.
I think ma'am has something to say. After that, sir, please ask you.
Yes, yeah, I'm just saying that this is totally arbitrary actually. At times, like, someone who has so many other things to do, even that 1 hour screen time seems too much. So I don't know whether that 1 hour, where does it come from, that 1 hour?
So, Tangavelu, sir.
Yeah, one question is, in a child with child taking AED, should you have to give routine vitamin D supplements? Is it a normal dose or double dose? Because they're likely to interfere with the vitamin D metabolism. What is the guideline says? Do they need routine vitamin D supplements, whether it is a normal dose or a higher dose?
It should be a normal dose. Giving vitamin D supplementation is not a bad idea to maintain bone health, especially in adolescents, older children who don't have much of sunlight exposure. And a routine supplementation is fine. So there is nothing like a double dose or extra dose. But if they are found to have hypovitaminosis D, then it should be corrected appropriately.
Thank you, ma'am.
Yeah.
Over to
Thank
Shivan.
you. All right, sir. So I conclude this session. It has been very interesting, and as we all are aware and as expected, questions are pouring in because it's a very common topic, and the talk has been very interesting, and it has provoked many questions as well in the discussion. So I thank every one of you for your contribution. And I thank Dr. Rachna Dubey ma'am for spending this much time with us. And I also offer my thanks to Dr. Rajesh Dani sir, Dr. Pandian sir, Dr. Annamalai Vijayaraghavan sir, and Professor GK for spending so much time with us and enriching the discussion with your inputs. I also thank Dr. Thangavelu sir and Dr. Mahesh sir for moderating the session. Next week, next Friday, we have a session on the basic management of cerebral palsy for pediatricians, the announcement of which will be sent subsequently. I thank every one of you for your contribution, and I wish you a good night, and thanks for joining us. Thank you.
Thank you. Thank you. Good night.
Thank you. Thank you.
Thank you, sir.
Thank you, sir.
Thank you.
Thank you, sir.
Good night.